And welcome to the topic Pityriasis Rosea in the Dermatology module. By the end of this topic, you should be able to define Pityriasis Rosea, explain the pathophysiology of the disease, outline the causes and classification of Pityriasis Rosea, describe the clinical manifestations, outline the investigations done, discuss the principles of management and the complications as well as the prognosis of Pityriasis Rosea. Let's get started. Pityriasis rosea is an acute self-limiting skin rash. Pityriasis means flaking or scaling of the skin. The word comes from the Greek term which is known as bran, referring to shedding of bran-like scales of epidermis. Rosea comes from the Latin term meaning rose, rosy or pink. So the literal meaning of Pityriasis rosea is fine pink scales. The pathogenesis of Pityriasis rosea is unclear, but there are few hypotheses observed. The proposed mechanism is due to lack of NK cells and B cell activity, which suggests a predominantly T cell mediated immunity. This also causes increased amounts of CD4 T cells and Langerhans cells present in the dermis and possibly reflecting viral antigen processing and presentation. Anti-immunoglobulin keratinocytes have also been found in patients with Pityriasis rosea. The causes of Pityriasis rosea include bacterial infections such as Streptococcus, reactivation of latent herpes simplex virus 6 and 7 infections. Post-vaccination such as BCG, influenza, H1N1, diphtheria, smallpox, hepatitis B and pneumococcus can also cause Pityriasis rosea. Drugs can be one of the causes of this condition too. The examples include gold, captopril, barbiturates, D-penicillamine, and clonidine. Pityriasis rosea can be classified into various types. The types are classic, relapsing, persistent, pediatric, pregnancy, and Pityriasis rosea-like eruption. So classic Pityriasis rosea begins with isolated herald patch lasting for 2 weeks, followed by secondary eruption that may last up to 12 weeks and prodromal symptoms of viral URTI. Atypical eruption is classified for the morphology with the size, number, distribution, site of lesion, severity, and cause of symptoms. Relapsing Pityriasis rosea is a variant of exanthum that recurs usually within 1 year from the initial presentation. Pityriasis rosea-like eruption is a drug-induced skin rash which strikingly resembles genuine Pityriasis rosea. Now let's look at the clinical manifestations. Initially, this condition shows non-specific symptoms similar to viral URTI such as fever, headache, stuffy nose, sore throat, and fatigue. The clinical presentation then followed by herald patch, which is erythematous, slightly elevated scaling borders with lighter depressed centers, which measure more than 3 cm in diameter that usually last for 2 weeks. Then, secondary eruption occur at the trunk along the Langer lines and may extend to the upper arms and thighs. The patch is usually smaller than the herald patch and appear up to 6 weeks after herald patch. This may last up to 45 days to 12 weeks. The distribution of rash on the back is a Christmas tree pattern, and the rash on the upper chest appear to be V-shaped pattern. This picture shows the distribution of the rash. The cause of disease that we have discussed earlier is pathognomonic of classical Pityriasis rosea. Now let's look at the atypical morphology. Atypical morphology includes vesicular, purpuric, urticarial, generalized popular, lichenoid, erythema multiforme-like, follicular, and giant Pityriasis rosea. So for vesicular, it is generalized eruptions of 2 to 6 millimeters in average and with rosettes of vesicles over the head, palms, and the soles. Macular purpura on skin or oral mucosa is the sign of purpuric or hemorrhagic type. The generalized papular type has multiple papules that occur along with classical patches. The lichenoid type is caused by drugs such as gold, captopril, barbiturates, and D-penicillamine. Let's discuss the investigations. Dermatoscopy can differentiate Pityriasis rosea from other conditions. Result of dermatoscopy shows yellowish background color, a peripheral arrangement of the scales, and a patchy distribution of loosely arranged dotted vessels. Histopathology of the skin lesion can also be done. Biopsy specimen would show superficial perivascular dermatitis. There would be focal parakeratosis in mounds, hyperplasia, and focal spongiosis, which are observed in the epidermis. Full blood count may show increased white cell count with differentials, and ESR is usually elevated. Total serum protein levels, globulin and albumin levels will also be elevated. Now let's go on to the treatment. The treatment of pityriasis rosea is supportive because it is a self-limiting condition. Topical zinc oxide and calamine lotion can treat the pruritus. If the disease is severe or widespread, topical or oral steroids may be needed. Patient education is important in the management. A patient should avoid the exposure to irritant agents such as harsh soaps, fragrances, hot water, wool, and synthetic fabrics. Tight clothing and scratching must also be avoided. Complications of pityriasis rosea are severe itching and brown spots after rash has healed. The prognosis of this condition is generally good because it is a self-limiting disease. In summary, pityriasis rosea is a mild skin disorder characterized by a salmon or pink-colored scaly rash. The pathophysiology of this is unclear, but there is noted to be a T-cell mediated immunity with low levels of natural killer cells and B cells. The causes are viral URTI, reactivation of herpes simplex virus 6 and 7, infections, vaccinations, and drugs. Clinical manifestations of this condition are herald patch followed by scaly oval patches on the trunk and proximal extremities in a Christmas tree appearance. Pityriasis rosea is a clinical diagnosis and the treatment is supportive. We have come to the end of this topic. Thank you.